The Asian American Pacific Islander Nurses Association of Nevada presents Healthy Mondays with AAPINA of Nevada. Start the week healthy and right with interesting conversations on living a healthy lifestyle. And now, your Healthy Mondays host, Dr. Mary Faye Axon Armstrong.
Aloha! Magandang gabi po sa inyong lahat. Maraming salamat po sa inyong pakikinig sa aming programa, Healthy Mondays with AAPINA of Nevada. And every Monday is a Healthy Monday. So I have a very special guest tonight. We are going to talk about Sickle Cell Disease, and I have a very special guest. He's my colleague and friend from the Substance Abuse and Mental Health Service Administration's Minority Fellowship Program. So let me just read. Welcome, Dr. Cheedy Jaja.
Thank you. To be with you this afternoon.
So I wanted to share with our listeners your background and before we start our informal dialogue. So to our listeners out there, Dr. Cheedy Jaja is an associate professor in the College of Nursing at the University of South Carolina, Columbia. And he is 28 years of teaching experience, that's many years, across the curriculum in nursing, social sciences, art, and humanities, and higher education across the United States. He is a board-certified psychiatric and mental health nurse practitioner, and he holds active RN licenses in the states of South Carolina, Washington, and Maryland. And what's so exciting about his background is it's conglomerate of many topics: public administration policy, community health nursing, public health genetics, philosophy, political science, translational science, and most of all, his research interests. And that's why I invited him to be our guest tonight about sickle cell disease. And he is very well versed with pharmacogenetics and healthcare disparities. He is currently doing research and clinical translation of inherited genetic variants in drug metabolizing enzymes, drug targets, and transporters that would foster the development of algorithms for the appropriate selection of analgesics for pain therapy in sickle cell disease patients. And also, this is most important, he's engaged in health systems strengthening and capacity building program in the West African nation of Sierra Leone, designed to address early morbidity and mortality through early diagnosis and evidence-based implementation science interventions. Wow, welcome, Dr. Cheedy.
That's a mouthful. Are you really talking about me or talking about somebody else?
Yes. Well, maybe you can share a little bit more personal information about yourself to our listeners out there.
Well, what can I say? I am very passionate about sickle cell disease. So when you asked me to come on board to talk about my interest, I could hardly say no. So I'm here to answer any questions you want to ask about, what I do in the area of sickle cell disease.
Well, first of all, can you share with us a little bit about your humble beginnings?
Oh my God. Okay, where do I start? I usually tell people that I am the poster child of very poor career decision making. What do I mean by that? As you can see from my bio, I have dabbled in so many different things, and to become a nurse. I was born in Sierra Leone, which is a very tiny country in West Africa. And I left Sierra Leone right after I finished my undergraduate degree, which was in philosophy. Okay. And right after I finished my undergraduate degree, I moved to the UK, to England, and I studied air traffic control. And actually worked as an air traffic controller, and for a bit, and then realized that this is not what I want to be. So I moved on, and my next venture was to actually study philosophy at the graduate level in the United States. So I studied philosophy, and broadened my interests include political science and international studies. I became a junkie for knowledge. So in 3 years, I ended up collecting 3 master's degree from 2 universities in Ohio. And then I moved around the country, lived in California for a bit, ended up in Florida, then decided to study, to pursue a doctorate degree. And wanted to do something new, but also something challenging. So I ended up pursuing a PhD in public administration. Finished my degree in public administration, then I got a job in Seattle, Washington. And not to teach public administration, but to actually teach philosophy, which I'd studied in my master's program. But while I was in Seattle, I discovered genetics. And I said, oh my God, this is exciting. This was around when the Human Genome Project was a big thing in science, and as a philosopher, I said the Human Genome Project is going to raise a lot of questions about ethics and science. Going to raise a lot of questions about what do we do with genetic information in the area of employment, in the area of insurance company having access to genetic information. So, I was very excited. I got to learn about this new science. So actually, we end up going back to school and got a master's degree in genetics. But while I was doing genetics, I said to myself, you know what? Maybe it would also be nice if I'm able to touch people. By touching people, I mean to provide care. And that's how I got interested, in the clinical, in having a clinical background. So as soon as I finished genetics, I ended up going to nursing school, to become a nurse. So I usually tell people that I took the scenic route to becoming a nurse. But I think all along, I was cut out to be a nurse because the kind of work that I do puts me in a position where I could actually be able not only to touch people, but actually to make an impact in their life. So I'm really living my dream right now.
It's always nice to hear our guests' personal information, how you end up doing what you're doing right now, and really it resonates your passion to help people. Not only passion to help people, but also to touch their lives in so many ways. So I know I'm excited to hear more about your story about. By the way, listeners, when he came on with this show broadcast, he has a picture of himself. Maybe can you plug that in the photo? I just wanted to segue in that.
Let's see if I could pull, because I'm not really that tech savvy, but try. Okay.
I promise it's worth seeing this photo.
Okay.
It will put a big smile on your face. Tell us a story about this photo.
Okay, so this was last year, I think it was June 19, World Sickle Cell Day. And this is in Sierra Leone, a town called Freetown, which is the capital of Sierra Leone. And on World Sickle Cell Day, we decided to do newborn screening, at one of the main children's hospital. And so these were two twins that I had the pleasure of conducting a newborn screening to see if they have sickle cell disease or not. And they were such delightful kids. I pricked them, and these kids did not cry at all. So they were like my heroes. And I had to take a picture of them. So, but it's a testament, of the work that I do and the joy that I derive doing this kind of work. Yes.
See, I told you it's worth seeing it because it paints a great picture of what you do in West Africa. And so, yeah, and then now you can probably turn off your video so then we can see just you.
All right. So how do we do that?
Yeah, so thank you for sharing that photo, Dr. Cheedy. Very momentum photo, I believe, for you, as those twins are your heroes.
Oh yes, oh yes. And the interesting thing about that picture too, though, is if you go to the American Nurses Association, that photo was selected as one of their profile picture to celebrate the Year of the Nurse, and so it's right there on the American Nurses Association website.
Yes, if you wanted to see it again. I think at this time would be a perfect time for us to really dive into what is really sickle cell disease.
Okay, so I'm going to try to explain it as simple as I can. So sickle cell disease is the most common genetic disorder in the world. Okay, so just to give you a perspective, in the United States, each year, approximately 2,000 babies are born with sickle cell disease. But in Africa, each year, approximately 300,000 babies are born with sickle cell disease. So the bulk of the sickle cell cases occur in Africa. The next part of the world where you have a high incidence of sickle cell disease is in India, the subcontinent of India. And then you have in the Caribbean, in Southern America, Brazil, Mexico, and much of South America. Okay, but like I said, it's a genetic condition caused by it's also a blood disorder. Okay, it's a blood disorder of the hemoglobin. Now, the hemoglobin, as we know, is what it's what it's an enzyme, that carries oxygen to the different organs of the body. So folks with sickle cell disease tend to have a defective hemoglobin. Okay, defective in the sense that under certain physiological condition, the hemoglobin become deformed. Okay, by deformed I mean it takes a sickle shape. It bends like a sickle. And that bending of the hemoglobin is the result of the downstream effect of the disease. By downstream effect, I mean all the mobilities that follow from having the disease. What do I mean by that? Well, like I said, the hemoglobin is what transmits oxygen to the different organs. Now, in those very tiny blood vessels that we have in the different organs, when the hemoglobin become deformed, when it become bent, when it take that sickle shape, it kind of like block, those small, tiny blood vessels. And we say those vessels becomes occluded. When they become occluded, our blood does not flow readily into the various organ. And that is the cause of the pain crisis that our patient experience over and over again. So that occlusion, that blocking of those tiny vessels on and off, on and off, over time, it's what causes multiple organ damages. And it's also what is responsible for premature death in a lot of patients with sickle cell disease.
And in your experience, how soon can an individual find out if they have the sickle cell disease?
Okay, so you could tell, that an individual, well, the easiest way you could tell, is at birth, when you do newborn screening, which is very common here in the United States. Every kid, gets screened for a variety of genetic or metabolic disorder at birth. That depends on the state, where they reside. So newborn screening is the easiest way to determine if somebody has sickle cell or not. Now, in other parts of the world where newborn screening is not readily available, the first manifestation, the first sign of sickle cell disease is when baby is around about 6 months of age that experience what we call dactylitis, and that is swelling of the arms, and the limbs, and then you will see, this kids, would cry out in pain. So the swelling of the arms, those dactylitis, is the very first indication that a kid is likely to have sickle cell disease.
Is there?
It's the earliest manifestation of what we refer to as a pain crisis.
Is there? I know you mentioned that sickle cell disease is genetic. So can you share with us the difference? If it is genetic, then it's also with, I guess, your ethnicity and your family history.
Okay, so in terms of the incidence of sickle cell disease, it is very common. It's very common in individuals who have an African ancestry. Okay, so why is that? Okay, well, the hypothesis is that sickle cell disease arise as a kind of, for lack of a better term, it arises as a reaction to malaria. Okay, so why do I say that? You find out that if you look at a map of the world, okay, we have areas that we refer to as the malaria belts. The malaria belt are parts of the world where malaria is very common, and so these are typically areas around the equator. Okay. Now we found out that in countries that are very close to the equator, the incidence of sickle cell disease is very large. Okay, and we also find out that the incidence of sickle cell traits is also very large. So the hypothesis is that that sickle cell trait is a reaction, or it's kind of like a genetic advantage against. It's a genetic advantage against sickle cell disease, because folks who have the trait, if they have malaria, the effect of malaria is very mild. The cause of malaria is very mild. Okay, so the hypothesis is that that sickle cell trait confer a kind of like genetic advantage to individuals in the sense that the susceptibility to malaria may not be fatal. But the downside effect of that is that when you have two individuals with the sickle trait, and if those two individuals end up having a child, then there is 1 in 4 or 25% chance that the baby or the offspring will have sickle cell disease. Now, an individual with sickle cell disease does not have that genetic advantage that individual with sickle cell trait have. So they tend to be very prone to infection. They tend to be prone to malaria. So actually, malaria is a very common cause, for early death, for early mortality in kids with sickle cell disease.
Well, very interesting. I'm learning a lot here. Yeah. But tell us more about your work, your mission in Sierra Leone.
Okay. So my mission in Sierra Leone happened by accident. And this is very interesting because sometimes I think that sometimes your mission in life finds you. It's not you who finds the mission. So I have been doing sickle cell work in the States for a number of years. My interest in sickle cell disease was very narrow. I was looking at how we could use genetic information. Remember, I mentioned that one of my background is in genetics. So my research was looking at how we could use a patient with sickle cell disease, their genetic information, to help with pain management. Pain is the most common cause. Pain is the most common manifestation of sickle cell disease. So individuals with sickle cell disease, would experience acute pain crisis that could last for days, sometimes weeks. Okay, and sometimes it's so severe that these individuals have to go to the ED or be admitted in the hospital. Okay, and they have to be managed, with opioids, with very strong opioid therapy. So my research was looking at how we could use genetic information to help manage, to help with pain management using opioids. And we found out, from genetic research that individuals, the way that they metabolize drugs varies from one person to the other. There's some individuals who would metabolize drug very fast. There's some individuals who metabolize drug very slow, and then some individuals who metabolize drugs, at a very normal or average rate, And that knowledge itself is very important in terms of how you titrate a pain medication when a sickle cell patient is in pain crisis. So my research was focusing on trying to find out who is a fast metabolizer, who is a slow metabolizer, and who is just your average metabolizer, and then use that information to say, okay, this is how we're going to dose and manage pain medication when this individual is in crisis. So that's what the kind of work that I was doing here in the States. And I don't know if you recall, in 2014, 2015, Sierra Leone and two other countries in West Africa experienced the Ebola crisis. Okay. And since I was originally from Sierra Leone, I decided that I should go to Sierra Leone and help out to take care of patients with Ebola. So I went to Sierra Leone and I worked in a Ebola hospital. And I recall vividly, one day I was at the hospital, and somebody came and said, "Oh, there's a group of people outside the hospital wanting to talk to you." So I said, "Well, what, am I in trouble?" I said, "No, they heard that you do work with sickle cell patient, so they want to talk to you about sickle cell disease." So I went out and I met this group of people and found out that they are from sickle cell patient advocacy group. And they've heard that, that I work with sickle cell patient, and they wanted to see if I could come to one of their meetings and meet, with the patient, and just maybe, talk to them and see, what advice, I could give them in terms of how to manage sickle cell disease. So I showed up at this meeting expecting to meet just a handful of people. And there were, I'm not making this up, over 100 individuals, parents with their kids, wanting to see this doctor from America, who, worked with sickle cell disease. So, I mean,
funny you mentioned that. It happened to me in Uganda. I was teaching there during the summer, and then they said, "Oh, we would like to invite you to do a presentation about your research about depression and how it is related to chronic illness." And so I went at the Mandela, the famous Mandela Stadium.
Wow!
And there it was. It was a midwives and nurses association where they had their annual conference. So I was caught off guard, and so I think this happened. But it's a good feeling that you're able to help. Right?
Yeah. Right. So this is what happened. So I spoke with those folks, found out that that there were no facilities first for early diagnosis, of sickle cell disease, there were no clinics for patients with sickle cell disease, and there was basically nothing, So I decided there and then that whatever I do next, have to be something that benefits, these patients. So when I returned back to the States, I was able to convince my university to allow me to use some of my research money to actually establish, a sickle cell clinic in Sierra Leone. So I was able to actually develop partnership, with other groups and individuals in Sierra Leone. So, for example, there is uh, uh, it's a federally qualified healthcare center that is based in Buffalo, New York. But they have a global outreach program, so they establish healthcare centers in different parts of the world. So Sierra Leone was one of those countries where there's a healthcare center in Buffalo, New York, and established a community healthcare center. So I was able to develop a memorandum of understanding with this group in Buffalo to allow me to use their community health center as my medical home for the clinic. So we were able to hire nurses, and a physician assistant, to run the clinic. So initially, we started out with 120 children who we provide free medical care for. And all they have to do is shop once a month, and we do a comprehensive wellness check and provide them with the necessary medication that they need to last them for a month. We also provide health education to the parent in terms of how to manage kids when they have sickle cell problems at home. Okay. So we started with that clinic, and then we move on to adults, and we try to identify adults. So we end up creating a registry of 2,500 adults. These are all the kids and adults with sickle cell disease. So what I've been working on is now trying to establish a clinic for the adults. Last year, I was fortunate to be awarded a fellowship by the State Department. It's called a Fulbright Award. So I spent 10 months in Sierra Leone working with the Ministry of Health, and our focus was on, okay, let's try to put a system in place whereby we could identify these kids very early at birth, and and make sure that we'll link them up to some type of care management system whereby these kids could be monitored at least for the first 5 years of life. The first 5 years of life is very important for kids with sickle cell disease because children with sickle cell disease are very prone to infection. And so in much of Africa, malaria, as I mentioned, is very common, but there are also other types of infection that these kids are susceptible to. So they need to be monitored for the first 5 years of life. Sadly, that is not the case in much of sub-Saharan Africa, in much of the country along the malaria belts, in Africa. So just to put things in perspective, I mentioned earlier that roughly about 300,000 babies are born annually in sub-Saharan Africa with sickle cell disease. The sad statistics is that between 50 to 90% of those kids will die before age 5. And they will die, some of them will die without even being diagnosed of sickle cell disease. When they die, their death will be attributed again to malaria, to anemia, to stroke, to something else other than sickle cell disease, just because there is no system in place to identify them at birth. like we do with newborn screening here in the state. So what we're able to do in Sierra Leone is we worked with a biotech company in North Carolina that have developed a point of care test for sickle cell disease. It's called the Sickle Scan. And we use that test in newborns, in infants, to determine whether they have sickle cell disease. And with that test, you could actually tell within 10 minutes if an individual has sickle cell disease. So that was a test that we used, and we were able to screen about 950 children to determine who has sickle cell disease. And that picture that you saw earlier was part of that exercise of screening kids. So we now have a second sickle cell clinic in the country. That kids with sickle cell disease can go for treatment. This summer, I was actually supposed to go back to Sierra Leone to now work on, developing a clinic for adults. But because of the COVID-19 situation, we have to put that plan on hold for now.
So that would be, I know that I didn't realize September 2020 is actually the National Sickle Cell Disease Awareness Month.
It is.
What I'm proposing to you while we're on here is to continue our interview in September to talk about the adult clinic.
I'll be delighted.
Because I know when I was working at bedside, taking care of individuals diagnosed with sickle cell disease, that it was a very painful disease, especially when they are in crisis. As you have mentioned,
Yes.
the impediment and the flow of the blood, because the hemoglobin is deformed.
Sickle, right?
Yeah, sickle. So then therefore there's not enough oxygen going around the body system. And so that's the pain. And usually when they come in for a sickle cell disease crisis, acute crisis, they will be put on that patient-controlled analgesic machine, which we call PCA, with, as you mentioned, the opioid medications. And I'd like to hear more in September when we interview again about how it works with the genetics when you are testing individuals and checking if they are ones who metabolize the medication faster, or they're ones who metabolize it slower, or the ones who metabolize them average. And that's how we as healthcare providers determine what type of pain management therapy that we can provide for this patient who have sickle cell disease and an acute crisis.
I would love to.
So time flies when we're having fun.
Oh,
so
yeah, is that time already?
Yes. So I'm really glad that we have you talk about sickle cell disease in your passion and your mission in West Africa. So Dr. Cheedy, do you have any words of wisdom to our listeners out there related to sickle cell disease or related to the global pandemic that's happening right now?
Well, I guess my message is we live in a global community. Okay, so to your viewer, I'm going to assume that the majority of them are going to be in the healthcare profession, and some of them are nurses. And I want us to look at our role, as clinicians, as healthcare provider, as not only that we have an obligation to provide the best optimal care, for the people within our own community, but as healthcare provider, our responsibility is global. Okay, so we need to have a global focus. Okay, and we have an obligation to provide care wherever care is needed. And that should be one of the tenets, that should be one of the principles that we should all hold dearly.
I couldn't agree more. Global collaboration, global,
exactly.
Because what happens in one country affects the other country.
Exactly.
And
exactly.
It's so well demonstrated during this COVID-19 go home.
Exactly.
So thank you again, Dr. Judy.
Thank you again.
Joining
It's
me
a pleasure.
tonight.
Thank
And
you.
thank you again, PHLB Radio, for your partnership to bring healthy information to our listeners out there. So remember, mga kababayan, listeners, every Monday is a healthy Monday. Aloha.
The Asian American Pacific Islander Nurses Association of Nevada has just brought you Healthy Mondays with AAPINA of Nevada.